Good morning. Welcome to the meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. I am Paul Casale, the chair of PTAC. So I think I speak for all the committee members that we're very excited to be here in person after being away for more than 2 years. Most of our committee members are here in the Great Hall of the Humphrey Building in DC after many virtual public meetings. And we look forward to a time when we can welcome members of the public to join us in person as well. As you know, PTAC has been looking across its portfolio to explore themes that have emerged from proposals received from the public. In March, we were excited to kick off a 3-meeting series of theme-based discussions on population-based total cost of care models. The public meeting focused on definitions, issues, and opportunities related to developing and implementing these models. Today and tomorrow, we will focus on care delivery model design. PTAC will hear about lessons learned from the public and subject matter experts, including stakeholders who have previously submitted proposals to PTAC that included relevant elements. We've developed an agenda to explore topics including what strategies have helped entities be successful in bearing financial risk while managing care for different patient populations, incorporating specialty care innovations into total cost of care models, measuring performance and evaluating these models, integrating episode-based or condition-specific models within a population-based model while reducing complexity, and meaningfully addressing equity. That's just a sample of what we hope to cover at this meeting. In September, we anticipate addressing the payment considerations and financial incentives that would encourage care delivery practices discussed today in total cost of care models. So if we don't cover a topic that's important to you today or tomorrow, you're likely to hear about it in September. You can also read our environmental scan and supplemental online material, which is part of our background materials for this series. After the September meeting, PTAC will issue a report to the Secretary of HHS with the committee's comments and recommendations on these topics. Today, we have multiple presenters ready to describe their vision and experiences related to assessing best practices in care delivery for population-based total cost of care models. Then the committee will discuss what we've learned before adjourning for the day. Tomorrow morning, we begin with opening remarks from Liz Fowler, the Deputy Administrator of CMS and the Director of the Innovation Center. We will also hear from many more experts from a variety of perspectives. We'll then have a public comment period. Public comments will be limited to 3 minutes each. If you'd like to give an oral public comment tomorrow, but have not registered to do so, please email ptacregistration@norc.org. Then the committee will have a discussion to shape our comments that will be included in the report of the Secretary of HHS that we will issue after the series. Taken together, the prep work, the presentations and discussions, and the public comments are aimed at informing PTAC about the latest knowledge from the field regarding the development of population-based total cost of care models in the context of APMs and physician-focused payment models. I'll note that, as always, the committee is ready to receive proposals from the public on a rolling basis. We offer 2 proposal submission tracks for submitters to provide flexibility depending on the level of detail that is available about their payment methodology. You can find information about how to submit a proposal online. So at this time, I would like for the PTAC members to please introduce themselves. Please share your name and organization. If you'd like, feel free to share a brief word about any experience you have with population-based payment or total cost of care models. So I'll start. I'm Paul Casale. I'm a cardiologist. I lead value-based payment and population health for New York Presbyterian, Weill Cornell, and Columbia University. Next, I'm going to turn to Lauren, and then we'll go around the room for each person to introduce themselves.
Good morning, I'm Lauren Hardin. I'm Senior Advisor for National Healthcare and Housing Advisors. I've spent the last 20 years leading and designing models and partner with communities, states, payers, and health systems, and standing up models, particularly for underserved and vulnerable populations.
I'm Larry Kaczynski. I'm a gastroenterologist and have spent the last 10 years of my life, 10 years of my career, building value-based programs for a company that I founded and functioned as a chief medical officer, Sonar MD. We are specifically currently focused on value-based payments in the gastroenterology space.
Hi, I'm Jennifer Weiler. I'm the Chief Quality Officer of UC Health's Denver metro area. I'm a tenured professor of emergency medicine at the University of Colorado and co-founder of UC Health's Care Innovation Center, where we partner with digital health companies to grow and scale their solutions to improve health outcomes for patients. I've held a number of leadership roles within specialty societies focused at developing payment models for providers and was a co-developer of an alternative payment model.
My name is Josh Lau. I'm an internal medicine physician and faculty at the University of Washington in Seattle. There I also serve as the enterprise medical director for payment strategy, so support a range of different payment models, including population-based total cost of care. I'm also fortunate to lead a unit called the Value and System Science Lab, where we do research and evaluation on these types of models. So think about methodologies and how do we evaluate if these models have yielded the benefits we want.
My name is Angelo Sinopoli. I'm a pulmonary critical care physician by training, presently the Chief Network Officer of Upstream, which is a company that enables primary care physicians to participate in global contracting. And prior to that was the Chief Clinical Officer for a large integrated delivery system, and they're founded and built a large network of about 5,000 docs, and then also founded a company called the Care Coordination Institute, which was also an enablement company for delivery systems to provide data analytics, care management, process improvement, et cetera. And I'm happy to be here today.
Good morning. I'm Walter Lin, internist based in St. Louis, founder of Generation Clinical Partners. We are a medical practice delivering care to the frail elderly in senior living facilities and also the seriously ill in their homes.
Good morning. I'm Lee Mills. I'm a family physician. I'm Senior Vice President, Chief Medical Officer of Community Care Managed Healthcare Plans of Oklahoma, where we operate a provider health system-owned total capitated plan across multiple lines of business. I came up through medical group management and operated multiple CMMI models and ACO models over the years. Thank you.
Good morning. My name is Jay Feldstein. I'm an emergency medicine physician by training, and I'm currently the president and CEO of Philadelphia College of Osteopathic Medicine. Prior to that, I spent 15 years in the insurance industry and healthcare, both for commercial and government plans, with a fair amount of experience in fully capitated and risk-based models. Chini, I'm going to turn it over to you now for your introduction.
Thanks, Jay. Hi, I'm Chini Puluru. I am Vice President of Clinical Operations for the Walmart Health and Wellness business. In this role, I oversee care delivery in our virtual care platform, our bricks and mortar clinics, behavioral health, dental, as well as our social determinants platform. Prior to that, I oversaw value-based care and care delivery for a large medical group, DuPage Medical, now Dewey Healthcare, where I oversaw implementation of value-based care platforms across the care continuum, growing it tenfold successfully.
Thanks, Jenny. Bruce, if you can introduce yourself.
Yeah, I'm Bruce Steinwald. I'm a mostly retired health economist in Washington, D.C. For the past 50 years, I've served in lots of different positions in government and academia and in private sector organizations, doing health economics and health policy in a variety of different settings.
Thank you. So now let's move to our first presentation. 5 PTAC members served on the Preliminary Comments Development Team, or PCDT, that has worked closely with staff to prepare for this meeting. I'm grateful for their time and effort in organizing today's agenda. At this time, the PCDT will present some of the findings from their background materials available on the ASPE PTAC website. PTAC members will have an opportunity to ask the PCD any follow-up questions afterward. So now I'm going to turn it over to PCDT lead Chinny and the rest of the team, Walter, Larry, Lauren, and Lee. So Chinny, I'm going to turn it over to you.
Great. Thank you, Paul, and thank you to the team that served on this, as well as the entire SB team that helped. So in this presentation, we will work to discuss best practices as well as trade-offs and barriers of delivery and adoption of total cost of care models. Next slide. I'm not seeing the slides. Let's see if I can.
One second, Chinny. We're going to try to get them up.
Great, thank you. Given the Thank you. Given the increased emphasis on developing alternative payment models that encourage accountable care relationships, PTAC is examining key issues related to development and implementation of population-based total cost of care models. The committee's March public meeting began by focusing on key definitions, issues, and opportunities. Today's meeting focuses on assessing best practices in care delivery for population-based total cost of care models. Within this context, PTAC is particularly interested in exploring options for integrating episode-based or condition-specific models within broader population-based accountable care models. From 2016 to 2020, PTAC received 35 stakeholder-submitted proposed physician-focused payment models that have deliberated and has deliberated on the extent to which 28 of these proposed models meet the Secretary's 10 regulatory criteria, including Criterion 2, which is quality and cost. Many of the PFPM proposals that have been submitted to PTAC include innovative care delivery approaches that could potentially be relevant for population-based total cost of care models. This presentation provides useful background information to provide context for the rest of today's discussion and tomorrow's discussion. Next slide. PTAC has been using the following working definition of population-based total cost of care models as a guide for focusing discussions during this series of theme-based discussions. A population-based total cost of care model refers to a population-based advanced payment methodology in which participating entities assume accountability for quality and total cost of care and receive payments for all covered healthcare costs for a broadly defined population with varying healthcare needs during the course of a year or 365 days. This definition will likely continue to evolve as the committee collects additional information from our stakeholders. Next slide. The Center for Medicare and Medicaid Innovation, CMMI, has set the goal of having every Medicare fee-for-service beneficiary with Parts A and B in a care relationship with accountability for quality and total cost of care by 2030. PTAC is using the following working definition of an accountable care relationship. And an accountable care relationship is a relationship with the healthcare provider that focuses on accountability for quality of care and cost of care for an individual patient or group of patients for a defined period of time. Within this context, an accountable care relationship would typically include accountability for quality and cost for all of a patient's covered healthcare services. However, in some cases, a provider could potentially be accountable for the quality and cost of a subset of a patient's healthcare services for an episode of care, which could be procedure-specific, condition-specific, disease-specific, or related to a particular medical event. Next slide. As we move from fee-for-service to a fully capitated integrated delivery model, there are potential implications to care delivery, and we have to take those into consideration as they impact the design of the models. First, as an organization takes on more risk, there needs to be significant improvement in care coordination, integration, as well as accountability clinically. This will require increased infrastructure outside of the provider-patient-facing episode. Next, as this need grows, there's also flexibility to innovate in care delivery, including finding new ways to integrate virtual and digital care, whether synchronous or asynchronous. This flexibility shifts the ability to innovate closer to the provider and patient-facing component part of care. One potential consequence that is necessary and can be viewed as limiting is the potential limitation of beneficiary choice. However, this isn't a negative effect, as it often can lead to higher quality, better outcomes, and accountability of the care delivery provider. Next slide. As we move from fee-for-service methodology to a fully capitated model along the risk continuum, the obvious is that there's increased financial risk for the accountable entity. This risk leads to increased accountability to improve value. This increased value is embedded in every model deliberated by the committee. The other payment factor trade-off is a reduction in beneficiary cost sharing. This acts as incentive for the beneficiary member to choose plans that hold the provider organization at increased accountability for both financial risk and value offered. As organizations take on more risk, there is a shift in health plan or purchaser administrative burden for payment determination to the accountable entity. One important factor in payment factor trade-offs is that it can reduce CMS administration or redistribute it to the accountable entity. As we consider models and total cost of care, simplicity to administer the model and financial reconciliation, as well as timing, is an important consideration. We will be hearing this from our committee as well as we move into future meetings. Next slide. There are some general consensus about accountable care that we've already recognized. For example, importance in maintaining a patient-centered approach, embedding and improving health equity across the continuum, increasing coordination between providers that are broadly responsible for accountable care relationship with patients, as well as integrating specialty providers, so all of the participating providers have access to tools to deliver high-quality, coordinated, team-based care. The importance of addressing and realizing health-related social needs and social determinants of care, the emphasis on outcome metrics and adoption of improved care delivery processes, focus on evidence-based high-value care, as well as a focus on reduction of waste and gains in efficiency, as well as maintaining budget neutrality, and seeking to reduce unnecessary complexity. Next slide. There are some areas where additional discussion is also needed. Whether value-based care delivery innovation should focus on high-cost patients with multiple chronic conditions and related episodes of care, or a more broadly defined population. How best do we support providers that are in accountable care relationships, particularly in cases where attribution occurs retroactively? What is the relative amount of accountability for individual providers versus a higher level accountable entity? Whether accountability can be shared among more than one provider, and if so, how does this work to distribute financial accountability? How do we integrate screening and referrals for HRSNs and social determinants of health into context of value-based care relationships? And what types of providers and organizations can serve as accountable entities? How do we expand that potential scope? how best to disseminate information about best practices and innovations to providers and organizations within these accountable relationships, and how much flexibility should accountable entities have in determining how to manage care for the services they're responsible for. Next slide. To picturize and discuss the elements of patient-centered delivery and integration, as well as accountability for diversity of patient archetype, these particular elements are in no hierarchical order, but rather evenly important, but they're divided into 4 different sectors. First, in considering different patient needs, we must consider that while most patients get their care with primary care physicians being the quarterback of their care, there are subsets of patients who often see their specialists in much higher frequency, and therefore often see this physician as their primary care physician. For example, a cardiologist for a patient with heart failure, or a nephrologist in end-stage renal failure. Models developed need to acknowledge these relationships and develop accountability for care. Second, in considering different needs, encouraging provider alignment and coordination is another element encompassed in total cost of care models. We need to look at attribution methodology to further incent this with primary care, even as with plurality is with the specialist. We must develop alignment across different touch points that the patient interacts with the healthcare system, including social service encompassing social determinants of health and long-term care. For example, a patient statistically potentially sees a pharmacist 11 times more than a physician. This is an important element to coordination of care and access to care. Leveraging all the ways the patient interacts with the healthcare system to affect coordination can't be underestimated in our total cost of care models. One of the most important elements of care alignment must take into account behavioral health of a patient and consider how to best help access to care, including funding that incentivizes providers to develop channels of delivery. Third, in delivering future models, we must consider innovation that matches the world we deliver care in. Systems such as advanced primary care, innovating the workforce platform to the top of licensure in team-based care. Innovating and encouraging clinical pathways that encompass virtual care as well as digital care that are both synchronous as well as asynchronous, encourages the patient to engage in their care more effectively, allowing for provider systems to innovate these pathways. Team-based care includes integration with community services that address social determinants of health. And the fourth element is a foundational element that encompasses all the other 3 elements, and that is tools, infrastructure, analytics, implementation, and best practices. We must support more ready access to data, real time to enable providers to effectualize appropriate care patterns, increasing and facilitating sharing between organizations and risk-bearing entities to encourage best practices. Some other elements that are in total cost of care models are financial planning, implementation resources to enable smaller, more independent, particularly in rural and underserved areas, to embrace all the elements that are needed to take on financial risk. Next slide. Considerations for integrating specialty care. It may be more effective to encourage patients to receive care from an accountable provider or from providers whose care is being coordinated through a specific accountable entity. However, this can limit patient choice. Some providers are not comfortable assuming overall accountability for patient-centered, value-based care if they only provide a portion of this patient's overall care. And some do not have the analytic tools or prerogative necessary to effect coordination of care with other providers. Integrating specialty and population-based total cost of care models will require addressing any unintended conflicting incentives built into benchmarks and total cost of care calculations for shared savings and losses that can also affect care delivery. These incentives may conflict across models and including episode-based models that are currently being implemented and tested separately and siloed. For example, the definition of which services are included in total cost of care can potentially incentivize cost shifting. Consistency in the technical implementation of incentives may help encourage participation in advanced payment mechanisms. Next slide. Some options for integrating specialty care, including nested models, hierarchical models within the ACO global budgets that operate as an umbrella for accountability. But this requires that the rules and technical implementation of key elements such as benchmarking and saving calculations be designed so they complement those relevant to the umbrella model. Next, carve-out models. Models that separate accountability for certain services outside of an ACO global budget. Other such considerations such as mandating provider participation, including specialty participation in population-based total cost of care models. Population-based total cost of care models may not be able to create sufficient incentives to engage specialists, in some cases due to a limited supply of specialty care in some markets, particularly underserved in rural markets. Voluntary participation may result in less accountability, integration, and coordination than would be desirable and necessary for ensuring quality and reducing total cost of care. Structuring technical elements of episode-based models so they are better positioned for integration into population-based total cost of care. Potential structural modifications include extending the duration of episodes into care bundles, making it easier to incorporate long-term quality of care measures into provider incentives, as well as addressing perverse incentives by encouraging participation and coordination between episode-based models, as well as larger total cost of care. One of the most important elements is encouraging coordination across accountable entities and population-based models to improve care for patients who do see providers in multiple models. If successfully done, this would incentivize coordination between accountable entities that may be taking on more or less risk. For example, between ACOs, between advanced primary care models and an ACO, or between multiple episode-based models and as well as an ACO. Next slide. One of the most important elements of success in a total cost of care model includes timely data sharing to maximize success. Many commercial population-based models include the ability for providers to monitor real-time data on utilization, cost, and other performance metrics. Some of the challenges to effective and timely data sharing in the current construct include a lack of interoperability, reliance on proprietary systems, lack of consistent funding for data collection and sharing, and lack of resources or in-house expertise for smaller practices. A lag of timely data on financial performance in population-based total cost of care models limits participants' ability to accurately forecast or benchmark expenditures and tempers the incentives and shared savings. Many new generation ACOs have stated that delays in shared savings payments make it difficult to use the potential payments to engage providers. Some new generation ACOs left the model altogether because they do not have enough information about their financial performance before the deadline for withdrawing in the next performance year. Some ESCOs have cited similar challenges. For example, one provider has stated, "The hard part is you make decisions now and you do not get a straight answer about what your outcome is. If the decisions that you made actually worked, so you are working blind in some situations for years at a time." Next slide. In the next two slides, we'll see some examples of care delivery model innovations. For example, Program for All-Inclusive Care for the Elderly, or PACE. Managed care plans and integrated delivery systems. So integrated delivery systems are vertically integrated health service networks that include physicians, hospitals, and post-acute services. Advanced primary care models targeting high-risk patients, and complex care management models. Next slide. Some specialty model innovations that have been interesting and tried are CMMI's comprehensive ESRD care model. This model allows nephrologists and dialysis clinics and other providers to form ESRD seamless care organizations, a type of ACO accountable for clinical quality outcomes and spending on dialysis services for Part A and B spending. Other models include diabetes care models. The Maryland Total Cost of Care model provides diabetes outcomes-based credit and provides recognition to Maryland for investing in initiatives and programs that assist with delaying and preventing diabetes over a course of time. Other models that illustrate this are serious illness models. Innovative approaches in PTAC models include several previous PTAC models included innovative care delivery approaches with the potential to improve quality and reduce total cost of care, such as primary care medical homes, specialty-based medical homes, remote specialty care supportive staff in skilled nursing facilities, as well as nursing facilities. Next slide. Unaddressed issues in performance measurement are significant, and measurement and evaluation are a significant part of developing total cost of care models. Identifying appropriate time periods. Cost and utilization measures may not reflect long-term patient care goals or patient-centered care. Addressing disparities. As we've seen with COVID-19, addressing disparities is such an important part of care delivery. Performance-based payments may actually exacerbate disparities if measures do not sufficiently account for variation in patient populations that the providers serve or different archetypes in different regions of the country. Data issues. Standardization of data elements. Standardization of data elements as well as variation in coding uptake and practice can affect performance measure viability. Selection. Issues related to selection and adverse selection may affect the ability to generalize the results of advanced payments methodologies more broadly. Refinement of risk stratification and severity adjustment. Delay in realizing return on investment for many organizations. Return on investment may be difficult to capture if the scope of the advanced payment methodology is broad. Associated costs and savings can't readily be captured, or ROI is experienced over a longer time period, making it difficult for organizations to put in the front-end investment. Smaller sample sizes. Issues with comparison and measurement for a smaller number of episodes pose a substantial barrier to performance-based payment tied to these performance measures, particularly in rural and underserved areas where these are much needed. APMs must also need to adapt and include new measures as we see emerging health issues occur. Next slide. So questions for the PTAC to explore. How do we encourage integration and coordination between primary care and specialty providers? Which care delivery innovations are most important for increasing provider accountability and quality with reduction in total cost of care with broad populations as well as patients with multiple chronic conditions? How to best integrate episode-based or condition-specific models within population-based accountability care models? How do we integrate referrals for health-related social needs and embed health equity by addressing social determinants of health within all models? How do we balance trade-offs involved in designing population-based total cost of care models that provide best value to patients? And finally, how to encourage and meaningfully support more providers in participating in value-based care and transitioning to population-based total cost of care models. Next slide. Thank you, Paul. I will go ahead and hand it over to you.
Thank you, Jenny. So before I open it up to the full committee, I'm just going to first ask the other members of the PCDT, Walter, Larry, Lauren, and Lee, if you have anything to add to Chinny's excellent presentation. So please turn your, flip your name placard on its end, just so I know that you would like to make a comment. Any comments? Larry, start with you.
I'll certainly break the ice and make the comment. The complexity of transferring risk from an organization down to individual providers appears to be one of our major challenges. And we can find entities to accept that global risk, but the only way you can really integrate care between primary care and specialty care providers is if they're also sharing in the risk. Current models today are heavily skewed towards primary care having capitation and specialists still being paid discounted fee for service. The other major challenges here in design are that not enough of a percentage of the total revenue of specialists is coming out of value-based care arrangements. We have to reach that critical threshold in revenue to specialists so that they become part of the solution and the care. So these are all significant challenges. I don't have answers to that, but hopefully our expert speakers later on today will give us some light.
Thanks, Larry. Any other comments before opening? Okay. Lauren.
So I'll just briefly add, one of the really interesting things as we look at total cost of care, equity, and social determinants of health is where does the payment belong as we move out across the community in partnership with multiple providers that we haven't thought of as part of our integrated system. So some of our speakers today will be addressing that, and it's a very important component as we look at really embedding equity in all of our models.
Thanks, Lauren. I'm going to open up now to all members. So, Angelo?
Yeah, I'll just add to some of the comments that it's not only figuring out how to include the specialists, but the specialists are so attached to the hospital as how do we include the hospital in that risk too, because they typically control the resources, the money, the budgets, et cetera. So.
Agree. By the way, Bruce and Chinny, if you have comments, just raise your hand and let us know that you have one. Other comments from committee members? Well, I'd say one of the things that struck, and there's a lot of great information that was presented, but along the lines of how to cascade that accountability and into what, how do you, and at what level, you can have a accountable entity, but then at the sort of rubber hits the road, as we like to, at the provider level, how are they going to feel accountable, and how do you do that within a total cost of care model? Again, I'm not sure the best way to do it, but I know that, it often starts with attribution, which we talk about a lot, so that the provider actually understands who they're accountable for. And then I think also mentioned by Chinny in the presentation is around adequate risk adjustment, because we know in the past, in the days of HMO, there was sort of shifting of high-risk patients as a way to manage your population, which, only made disparities worse rather than trying to address them. So, two, in my view, important issues that sort of underpin a lot of this. So hopefully we'll hear more from, during the day around, lots of areas, but particularly, I'm always thinking about the provider at the provider level. For them to participate, they have to understand, who their patients are, adequate risk adjustment, and then how do they understand their accountability within the system.
The great presentation, excuse me, and I had a question really maybe for the whole committee, but maybe starting with the PCDT. I like that schematic that was shown about the care delivery trade-off. There's always put and takes there, and a few slides later when we talked about picturizing kind of what that would look like. There were a few boxes about care pathways and different delivery models. So I'm wondering, in the work to put this report together, was there anything about, as we think about those arrows showing, flexibility in the care delivery model design, but potentially limitation in beneficiary choice? Was there also anything we heard related to changes in how clinicians practice? There may be flexibility in the delivery model design, but there may be a desire to reduce unwarranted variation. And so what would that look like as clinicians practice as we move to the right of that schematic, particularly as we then braid that together with this idea of cascading accountability? So I'm curious if there are any thoughts or comments that came up there.
Yeah, I'll take a first pass at that. So one of the things I think that was articulated in there was innovation in care delivery, but also looking at how do we embed things like telehealth and digital care, both synchronous and asynchronously. And when combined with a care team that would actually leverage all of, the example with the pharmacist, that would leverage all of the touch points that a patient has with not just their physician or provider, but with the entire healthcare system in order to effectualize that care. I think that was sort of the innovation that was discussed, when we were kind of deliberating.
Lauren?
Josh, I would just add, across the country, in addition to our research and what I'm seeing in practice, so it's definitely weaving systems together. So it's no longer a problem to have a behavioral health visit occur in the primary care office and weave those together in the same day, and the same in the community. So right now, homeless services, for example, are separate from healthcare services. When you weave them together into an integrated system, you stabilize the population much quicker. People get the care in the site where they want to receive it and where they spend the majority of their time. And there's efficiency then amongst providers, and then you get the results.
And I think that speaks to, I think, the schematic right below that about the payment trade-offs, thinking about how do we then, it's staying with me, the first slide about covered services and how does that come together? And
yes,
Chinny's point about telemedicine, is there a shift in how we think about paying for things in the fee schedule and elsewhere? I think that was something that came out, and the schematic helped me kind of see that. So I appreciate that.
Yeah, just to follow up on what's been said, one of the things I've heard, and I think we all know from our practical experience, is in the U.S., care follows finance. And as a result, incentivizing the frontline providers in the appropriate way on both quality and cost performance is super important. That's why we're really excited to hear from our subject matter experts today who have really innovative care models, but also payment models to support those care model innovations. I think often what we see are care models that are very successful from a quality and patient care perspective, but when not linked with the appropriate payment model, they fail to survive.
Yeah, I would agree with that. I'm thinking of many of the primary care providers in my organization are still in a very fee-for-service RVU-based system, and as busy as their each encounter is, and all the things they need to do, it's virtually impossible for them to be thinking more broadly. And so, how to switch that payment model so that they can actually, think around the population that they're accountable for. And so we're looking forward to hearing from our speakers today about all of that. Other questions or comments? If not, I want to certainly thank Chinny, Walter, Larry, Lauren, and Lee. Extremely helpful background to set the table for our discussion today. So at this time, we're going to take a break until 10:30 Eastern Standard Time. Please join us then. We have a terrific lineup of guests for our first listening session of the day.
produced by the U.S. Department of Health and Human Services.